Hello, I'm Maria Williams with the Collaborative on Health and the Environment. CHE enjoys bringing you the latest environmental health science through our partnership calls and webinars, science serves, publications, and social media. I would like to welcome everyone to today's CHE partnership webinar, which is titled Environmental Chemicals and Preterm Birth, Emerging Threats and Priorities for Future Research. Our moderator today is Rachel Morello-Frosch, professor in the Department of Environmental Science, Policy and Management at UC Berkeley. We will leave time following the presentations for a brief Q&A session. You may type in questions through the Q&A feature available on the menu bar at the top of your window at any point during the presentations. After the presentations, our moderator will read out questions for our panelists to respond to. We will get to as many comments and questions as we can during the Q&A period. For those of you who called in on the phone, we have posted slides to accompany today's webinar on our website. You can download these by going to healthandenvironment.org. Please scroll to the bottom of the page and select today's webinar. On the webinar page is a link to the slides. Everyone on the webinar right now is muted with the exception of our moderator and our speakers. This webinar is scheduled to last for 45 minutes and is being recorded for our call and webinar archive. With that, I'll turn things over to you, Rachel.
Thank you, Maria. Welcome, everyone. Good morning. I'm very excited to be moderating today's panel on environmental chemicals and preterm birth, looking at emerging threats and priorities for future research. As background, about 1 in 10 babies in the United States are born prematurely. And in 2015, preterm birth and low birth weight accounted for about 17% of infant deaths in the United States. And despite our best efforts as public health practitioners and researchers, the causes of preterm birth remain unclear, and our ability to reduce rates remain underwhelming. Yet mounting evidence links environmental contaminants to preterm birth, and identifying the contribution of environmental chemicals is becoming much more of a public health priority. Accordingly, today we have 2 outstanding guest speakers on this important topic. Our first speaker is Dr. Kelly Ferguson, who's an investigator who's leading the Perinatal and Early Life Epidemiology group within the Epidemiology branch at the National Institute of Environmental Health Sciences. She received her MPH in Occupational Environmental Epi, as well as her PhD in Environmental Health Sciences from the University of Michigan School of Public Health. Dr. Ferguson will be presenting first her work on prenatal exposures to endocrine disrupting compounds with a focus on phthalates and their association with adverse pregnancy outcomes, particularly preterm birth. She'll look also at how chemical mechanisms and phenotypes of preterm birth have enhanced scientific understanding of epidemiologic associations. Our second speaker is Dr. Amy Padula, Assistant Professor of Obstetrics and Gynecology and Reproductive Science at the University of California, San Francisco. Dr. Padula received her PhD in Epidemiology at UC Berkeley and had postdoctoral training at Stanford University. Dr. Padula will present her research, which is part of her K-99 award, Transition to Independence, from the National Institute of Environmental Health Sciences, in which she is looking at traffic-related air pollution exposure during pregnancy and preterm birth. She's going to discuss the incorporation also of neighborhood socioeconomic status as a potential modifier of observed effects between air pollution and preterm birth, and is also looking at diabetes as a potential mediator in the relationship between traffic-related air pollution and preterm birth. She'll also look at future plans for understanding how environmental chemicals shape preterm birth. Each speaker will have about 15 minutes to present, and then we will finish the call with about 10 minutes of Q&A. So I'm going to turn it over now to Dr. Ferguson as our first speaker.
Thanks, Rachel. And thank you very much for having me on this webinar today. I'm very honored to be part of this group of investigators who are under 40 in environmental health. So today I'm happy to be able to share with you some of my own research looking at environmental chemical exposures in preterm birth. So the overarching research objective of my research group is to improve the understanding of how the environment impacts pregnancy and childhood health. And this research really falls under 3 domains. So first, I'm interested in environmental exposure. So Rachel mentioned phthalates, but I'm also interested in other non-persistent chemicals like phenols, polycyclic aromatic hydrocarbons, metals, and non-chemical stressors like psychological stress and diet. I'm interested in how these exposures relate to oxidative stress in the mother, but also in the placenta, the fetus, and the father, and how through this pathway, environmental exposures can affect adverse perinatal and early life health outcomes. I focus primarily on preterm birth, but also fetal growth restriction, preeclampsia, and fetal loss. And today I'm going to talk to you about phthalate exposure in the mother, how this relates to oxidative stress, and how through this pathway phthalates can relate to preterm birth. So as Rachel said, preterm birth is a significant public health problem. It's defined somewhat arbitrarily as delivery before 37 weeks gestation, and it affects about 1 in 10 pregnancies in the US. It's a very important risk factor for neonatal mortality and morbidity, and it's associated with really high healthcare costs, as well as adverse health outcomes for the child and later in life. This is a major public health priority both for policymaking, but also to gynecologists and obstetricians. So this panel on the right is a statement from the American College of Obstetricians and Gynecologists, and it really has called for improved understanding of how chemical exposures can impact adverse pregnancy outcomes, so that clinicians can be more aware of how chemical exposures are important and can counsel their patients appropriately. Also, as Rachel said, the understanding of how environmental factors relates to preterm birth remains very limited. There's pretty strong evidence for classic contaminants like lead, persistent organic pollutants like DDT, and some air pollutants, but studies of non-persistent chemicals like phthalates remain pretty limited. So in this study, we were interested in looking at the relationship between phthalate exposure during pregnancy and preterm birth. Many of you may be familiar with phthalates. These are chemicals that are used to soften plastics primarily. They're found in vinyl flooring and other soft plastics like shower curtains and food packaging materials. They're also used in a lot of personal care products like perfumes, deodorants, shampoos, etc. Phthalates are absorbed readily into the human body. So if you consume contaminated food or beverages, you can be exposed that way, but you can also be exposed through your skin or through inhalation pathways. Once phthalates make their way into the body, they're metabolized pretty rapidly over the course of 1 to 2 days. And then excreted, but despite this rapid metabolism, levels are consistently detectable in populations worldwide, which kind of indicates a constant exposure. Phthalates have been associated with an array of adverse health outcomes, including hormone disruption, but also infant neurodevelopmental outcomes and some poor pregnancy outcomes. So in our study, in order to look at the relationship between phthalate exposure and preterm birth, we used data from the Life Codes birth cohort. This is an ongoing prospective birth cohort that's conducted by maternal fetal medicine specialist Tom McElrath at Brigham and Women's Hospital in Boston. Key features of this study include that women are recruited very early in pregnancy, so prior to 15 weeks gestation, and they provide biological specimens at 4 time points during pregnancy, so at median 10, 18, 26, and 35 weeks gestation. There's also really strong validation of adverse pregnancy outcomes in this study. Gestational age is calculated based on the mother's report of last menstrual period in combination with an early ultrasound. And all cases of preterm birth are examined by 2 maternal fetal medicine specialists to verify gestational dating and also to determine the reason for delivering preterm. So a lot of clinical studies separate out preterm births based on the reason for delivering preterm, but this isn't done very commonly in environmental epidemiology studies. So in our analysis, we separated preterms into 2 groups, spontaneous and placental preterm birth. And this was done based on a paper that my collaborator, Tom McElrath, wrote, in which he examined presentations of prematurity in combination with features of placental histology. And what he did was he identified 2 different groups. So the spontaneous preterm birth group presented primarily with preterm premature rupture of the membranes or with spontaneous preterm labor, and placenta from those groups had indicators of kind of an overwhelming inflammation. The other group, placental preterm birth, the cases presented with intrauterine growth restriction or with preeclampsia, and the placenta from those cases had evidence of poor placentation, but they didn't have the same kind of inflammatory phenotype. So in our analysis, we sought to examine these two groups separately within preterm births in order to better identify associations with phthalate exposure. So we performed a case control study of preterm birth, which included 130 cases of preterm birth that delivered between 2006 and 2008 in life codes, as well as 350 unmatched controls. And this study was designed by John Meeker at the University of Michigan. So we separated out our 130 cases of preterm birth into 56 spontaneous preterms, 35 placental, and then there was a group that didn't fall into either category that we did not analyze separately as they have no known unifying mechanism. To assess phthalate exposure, we measured a panel of 9 urinary phthalate metabolites in samples from each of those 4 study visits. So this is really a strength of this study, is that we were able to assess exposure by measuring phthalates at multiple time points. Most studies before this had only looked at phthalates in one sample during pregnancy. So we assessed total phthalate metabolite concentrations using mass spectrometry, and this was done by a lab in Ann Arbor, Michigan, NSF International. And we measured urinary specific gravity to adjust for urine dilution. And as I go through the presentation, I'll kind of highlight, we particularly are going to look at the high molecular weight phthalates today, including the DEHP metabolites. Exposure to these occurs more commonly through diet. And then also low molecular weight phthalates, which are thought to, exposure is thought to occur more commonly through use of personal care products. So in our primary analysis, we took an average of the phthalate metabolite measurements from multiple time points during pregnancy to create a more stable estimate of exposure in the mothers in our study population. And we divided these averages up into quartiles. And what we saw was that mothers who were more highly exposed to phthalates had an increased risk of preterm birth. So in this upper panel, you can see that mothers in the upper quartile of exposure to MECPP, which is one of the DEHP metabolites, one of the high molecular weight dietary phthalates, mothers in the upper quartile had about a 2-fold increase in odds of overall preterm birth. However, when we separated the cases out based on spontaneous versus placental, we saw that association was primarily driven by associations in the spontaneous group. So you can see here mothers in this upper quartile had about a 5-fold increase in odds of having a spontaneous preterm birth. Next, we wanted to use these repeated measures of urinary phthalate metabolites to see if we could identify any windows of vulnerability to exposure during gestation. And we did this by modeling the repeated measures across pregnancy. So you can see here on the x-axis, we have gestational age in weeks. And on the y-axis, we have concentrations of this MECPP metabolite again. And we looked at levels over pregnancy in cases of spontaneous preterm birth, shown in light gray, and compared those to controls, which are shown in dark gray. And what we saw here was that levels were very similar early in gestation, but tended to diverge as pregnancy progressed. So this really kind of highlighted later pregnancy as a potentially sensitive window for exposure to phthalates for the relationship with spontaneous preterm birth. So overall, this analysis really showed the utility of kind of separating out this, not very homogeneous pregnancy outcome of preterm birth into different groups, and also the utility of having repeated measurements of phthalate exposure for assessing windows of vulnerability. So we saw this association between phthalate exposure and prematurity, but we wanted to go further than that and say, what is the mechanism that's underlying this association? And we hypothesized that this could be due potentially to phthalate-induced oxidative stress. Phthalates have been shown to induce oxidative stress in vitro studies, and so we wanted to investigate that in our population of pregnant women. To do that, we measured 8-isoprostane, which is a biomarker of oxidative stress that's the product of arachidonic acid lipid peroxidation. And then this marker has been established by the Biomarkers of Oxidative Stress study at NIEHS as one of the best biomarkers of oxidative stress. It's very sensitive, it's very specific, and it's consistent across studies. And it's also very easy to measure in stored urine specimens. So in our study, we also measured 8-isoprostane as a biomarker of oxidative stress in all of the urine samples where we had also measured urinary phthalate metabolites, and we took a look at the associations using repeated measures models. And what we saw were very clear positive associations between phthalates and oxidative stress. So you can see here that most of the associations we examined were statistically significant, kind of showing that across the board, phthalates were associated with increases in oxidative stress. We also noted that the associations were greater in magnitude for this 8-isoprostane marker as compared to another marker that we measured. And we saw that associations with the low molecular weight phthalates, the ones that occur through personal care product use, were more strongly associated with 8-isoprostane compared to the other phthalates. Next, we wanted to look and see, okay, so we see this association between phthalate exposure and oxidative stress, but is there a relationship between oxidative stress and preterm birth? This had also been hypothesized, but not particularly well demonstrated. So we looked at these averages of our isoprostane biomarker in relation to preterm birth, and we saw an association again. So an increase in isoprostane was associated with about a 2-fold increase in odds of overall preterm birth. And we actually saw the same pattern that we saw with the phthalate metabolites. So you can see here when we separated out the phenotypes based on spontaneous and placental, we saw that the associations with spontaneous preterm birth were very strong. So isoprostane was associated with about a 6-fold increase in odds of spontaneous preterm birth, but no association was observed with placental preterm birth, really suggesting that the spontaneous preterm birth outcome is more important for the oxidative stress relationship. Finally, we performed a mediation analysis, adapting the existing causal framework to examine whether or not 8-isoprostane was a statistical mediator of the relationship between phthalate exposure and prematurity. And in this analysis, we examined the indirect or the mediated effect of phthalate exposure on preterm birth through isoprostane, and then compared this to the total effect, which is the combination of this effect as well as effects through other pathways. And what we observed was significant mediation by 8-isoprostane, kind of confirming the individual associations that we saw. And we also observed a higher proportion mediated for spontaneous preterm birth. So we observed some really interesting associations here, and I just wanted to touch on some of the future directions for my research group in which we're going to follow up these findings. So I presented data on phthalates today, but we're also aware that exposure to chemicals doesn't occur in isolation. So phthalates in particular come from personal care products frequently. And there's a lot of other chemicals that are in personal care products as well. So we're interested in exploring how co-exposure to these chemicals could relate to preterm birth and other adverse pregnancy outcomes. We're also interested in other chemicals that may act by this same oxidative stress pathway. For example, polycyclic aromatic hydrocarbons, which are found in grilled meats, are well known to increase levels of oxidative stress. And we're also interested in examining how these chemical exposures interact with non-chemical exposures like psychological stress during pregnancy. We're also interested in exploring what these oxidative stress biomarkers actually mean. We see an increase in 8-isoprostane, but it's not necessarily telling us what pathways are being activated and are important for the adverse pregnancy outcome of preterm birth. So in our group, we're further exploring this by measuring non-targeted metabolomics profiles to see if we can gather more information about what pathways are important here. And finally, we really showed the utility of examining phenotypes of preterm birth for identifying associations with phthalate exposure. We saw a suggestive association when we looked at the association with overall preterm birth, but really separating it out enabled us to see more clearly the association with phthalates and also to understand a potentially important mechanism by which phthalates could be acting on preterm birth. So we're interested in seeing if we can disaggregate other pregnancy outcomes in order to better establish associations with environmental exposures or to better study those associations. And I'm particularly interested in doing this in the context of fetal growth restriction. So with that, I'll thank my collaborators, particularly John Meeker at the University of Michigan and Tom McElrath at Brigham and Women's Hospital, and my funders, and I'll turn it back over to Rachel.
Thank you so much, Kelly. Can people hear me? I keep getting kicked off for some reason, but luckily I have the slides. Now I want to turn it over to Dr. Padula for her presentation, and then after her presentation, we'll take questions on both of these research talks.
Okay, great. Thanks, Rachel. Okay. Hopefully everyone can see my slides. So today I'm going to talk about traffic-related air pollution exposure during pregnancy and preterm birth in California. And Kelly gave a great overview of preterm birth, so I can kind of skip right into the exposure. So just to give a little bit of background about air pollution. So air pollution is regulated by the US and the California EPA, and it has been for more than 40 years as part of the Clean Air Act, and they set standards for what is considered a safe level of air pollution, and over time, as we've accumulated more showing adverse health effects, they've lowered the acceptable levels, and air pollution has actually decreased over this period. And so today I'll be talking about carbon monoxide, nitrogen dioxide, two different sizes of particulate matter, and we also looked at traffic density in relation to preterm birth. And this little slightly fuzzy diagram just shows some of the sources of air pollution. They're both kind of natural and man-made sources, and certainly cars and mobile sources are a big contributor, especially in California. So today I'm also going to focus mostly on particulate matter, and so this is just a diagram to show kind of how small particulate matter is. So PM10 is 1/5 of the diameter of a human hair, and then PM2.5 is 1/4 of that. These particles are inhalable, and PM2.5 especially can get into our bloodstream. PM10 is more often just kind of hits the back of our throat and gets ingested, but both get into our bodies quite easily. And this is a map of the US just showing, it's a few years old, but it shows the counties that didn't meet the standard for PM2.5 when they lowered it recently. And I just wanted to point out kind of this area of California, which is known for high levels of air pollution. And this is where I'm focusing today. So our study is among all births in these 8 counties in the San Joaquin Valley of California between 2000 and 2006. So, and we only used singleton births. So this turned out to be about 250,000. And we looked, and we had their geocoded residence at birth, the maternal geocoded residence at birth. And we used up to 3 monitors, EPA monitors, and then also monitors from other studies of air pollution in the valley to estimate a woman's exposure to air pollution during her pregnancy. And we looked during each trimester and over the course of the entire pregnancy. And we looked at preterm birth, not just as a dichotomous outcome of less than 37 weeks, which is its usual definition, but also at different gestational ages. So we were concerned with these early preterm births, although they are a smaller proportion of preterm births, they have more adverse health associations and more neonatal death associated with them. So, and in this study, we weren't able to separate kind of spontaneous versus indicated or placental preterm birth, but in many cases, these early preterm births end up mostly are spontaneous. So that was an interesting distinction that Kelly had made. So here are some of the results that stood out from this paper that was published a few years ago. So we found that the second trimester turned out to be the most strongly associated with preterm birth for all of the pollutants. And so this shows all of the kind of odds ratios comparing the highest quartile of exposure to the lower 3 quartiles. And I bolded the ones that were statistically significant rather than including all the confidence intervals. But one thing I wanted to point out is for these late preterm births, the ones born at 34 to 36 weeks gestation, there is a small but consistent and statistically significant association with preterm birth. So there's a 10% increased risk for these late preterm births when mothers were exposed during their second trimester to the highest quartile of exposure. But another thing I want to point out with these results is that the associations were stronger for the earlier preterm births. And this may be because they're more spontaneous or that association is stronger. But this was important to us because this is not often looked at in previous studies of air pollution in preterm birth. Okay. And this graph shows the associations just among PM 2.5 and preterm birth, but showing how it differs across the different trimesters of exposure. So in the first trimester, there wasn't much of an association, and if anything, it was in the unexpected direction for the early preterm births. The third trimester, we have a few missing dots because the babies born very early don't have a third trimester. And then you can see with those green squares, the second trimester, how those results really stood out to us. And here's a similar pattern, but for PM10, showing the different trimesters. So you can see that pattern of the earlier gestational ages being more strongly associated with high air pollution exposure. So we are interested, as many people are, in kind of mixtures of pollutants and kind of cumulative exposures. And this is just a very simple way of approaching that. I'm sure that there are certainly more statistically robust and more sophisticated ways of doing this, but we just came up with a very simple multi-pollutant score, where if you were in the highest quartile of a pollutant, you'd get a 1. And then if you were in the highest quartile for multiple pollutants, you'd have the number. So it ranged from 0 to 5. And then these are the results for just the second trimester exposure for scores 1 through 5 on the bottom, and then the odds ratios are on the y-axis. So for the late preterm birth, the 34 to 36 weekers, there was a small but consistent association, just regardless of whether they were exposed to a high level of 1 pollutant or 5. And then for the 32 to 33 weekers, the associations kind of wiggled around across the numbers of multiple pollutants. And then we started seeing a kind of pattern. So the earlier preterm births showed a stronger association as they were exposed to high levels of multiple pollutants, with the early preterm births really standing out once again. And then I wanted to point out, this is also in that same paper, we were interested in the role of neighborhood socioeconomic status. And these are some results kind of pulled out of there for that second trimester, only among these early preterm births. But this is where we saw this strongest kind of divergence. And we defined neighborhood or low neighborhood socioeconomic status as living in a block group with more than 10% unemployment, more than 15% of income from public assistance, and with more than 20% of families living below the poverty level. And we saw that the associations between air pollution and these early preterm birth were stronger in these communities of low neighborhood socioeconomic status. And they were statistically different from the higher levels of socioeconomic status. So this points to a kind of the double jeopardy idea that that being exposed to pollution and kind of adverse socioeconomic conditions can lead to worse health outcomes. And I just wanted to, this is kind of a sub-study of the study I just described, but this is only in Fresno County, and we were interested in polycyclic aromatic hydrocarbons, which this is one of the constituents of PM 2.5, and they're formed when there's incomplete combustion of gasoline or coal, and they've been associated with adverse health outcomes, and they're generally not monitored or regulated by the EPA. However, these monitors were set up around Fresno as part of the Berkeley Stanford Children's Health and Air Pollution Study. So we looked at PAHs during pregnancy, just among a subset. So this is the same years, but among about 40,000 births. And we saw, and so again, the odds ratios are bolded when they're statistically significant. We did find some in the unexpected direction, kind of showing a protective effect in the first trimester and the entire pregnancy for the early preterm births, which aren't quite able to explain. And then when we looked kind of backwards from the birth date for the last 6 weeks of pregnancy, we found a strong association between PAHs and preterm birth. And this was comparing the highest quartile to the lower three, as we had done previously. And when we looked more closely into each quartile, we saw a kind of exposure response and an increase in association for across each quartile. And so, so some of our next steps in trying to tackle the effects of environmental chemicals on preterm birth. One investigation I'm currently looking at is that diabetes and hypertension as potential kind of modifiers. So both have been associated with preterm birth, and both have been associated with air pollution, but we don't know whether those who are, whether these conditions may be kind of on the causal pathway between air pollution and preterm birth. And another thing that we've been working on and will continue to work on is looking at using the CalEnviroscreen, which includes not just air pollution, but other environmental contaminants throughout California. And we can look at that in relation to preterm birth. And that also includes social factors that were incorporated from the census, but additional environmental pollutants, including pesticides and water quality, among others. And then I wanted to mention the ECHO study, which is the environmental influences on child health outcomes, which is just started in the last couple of years, and taking cohorts from around the country and kind of putting them together to tackle environmental exposures and preterm birth, among many other child health outcomes. And we'll be looking at perfluorinated chemicals and phenolic compounds and their relation to adverse birth outcomes, and also incorporating psychosocial stress as an additional kind of exposure and also as a potential mediator. And then finally, I've done a fair amount of work with the National Birth Defects Prevention Study looking at air pollution and other environmental contaminants, including pesticides, with the outcomes of several structural birth defects, and also including gene-environment interactions as well, and we'll continue that work. So I just wanted to thank my collaborators and funders, and then open it up to questions.
Adorable picture. Okay, so truth in advertising, I'm having some challenges, connectivity challenges. So I'm going to read questions, but I also may need Maria's help if I get cut off again from Zoom. So the first question that appeared, and I think this is in response to Amy's presentation, which is, this is an area that also has high exposure to pesticides. Have you or has anyone looked at the interaction between air pollutants and pesticides, or even seasonality of conception, assuming that different pesticides are applied at different times of the year?
So this is a really good question. Actually, I have kind of two different answers, both on the kind of pesticide side and the seasonality side. So we have looked at pesticides in relation from pesticide use reports, and surprisingly, we were really expecting to find associations with preterm birth, and we did not. It is, I think there are several kind of explanations. I think some have thought that it may be that those who are associated to higher levels of pesticides either don't get pregnant or have earlier loss, and maybe that is why we see, because in many cases we see it, in the unexpected direction. But that has been somewhat of a mystery to us as to why we don't see a stronger signal, because the signal with air pollution is pretty consistent across many studies. The seasonality thing is quite interesting, because both pesticides and air pollution change quite a bit through different seasons of the year. And there's also strong patterns of preterm birth that changes through the year. So actually separating, we actually did end up doing both controlling for season and also looking within each month. Since we had a lot of data, we looked at stratified analyses by month, and we do see some stronger associations during certain times of the year. But it was really hard to tease out as kind of a confounder, because certain that preterm birth rates do change, and even consistently throughout the year in these cycles, and they're quite similar to air pollution. But it could also
be... So
a
follow-up to that question was also thinking about seasonal effects in terms of extreme, higher temperatures in the summer,
right,
or extreme weather events that are more likely to happen during warmer months, particularly that region.
Right.
Any thoughts on that?
Yeah, I personally haven't done work on that, although that is of interest. I think Colleen Reed has done some work on temperature changes and preterm birth. And I think, it is definitely difficult to kind of tease out these environmental factors, because they come together. We'll have high ozone, we'll have high temperatures, we'll have, but we ended up actually finding associations that were stronger when kind of in the more winter months. So for us, the temperature wasn't a huge signal for us.
Okay, great, thank you. Next question was, how do both presenters feel your findings would differ, if at all, for populations in other regions of the world? Would they potentially be different for areas in Southeast Asia or Central America with different exposure profiles than the US population shown here?
I can start since Amy just talked for a little bit. In terms of phthalate exposure, there is certainly variability across populations across the world. Phthalates seem to be a concerning exposure everywhere. And in the US, they may be particularly high compared to Scandinavian countries. I'm not sure off the top of my head how exposure levels compare to East Asian countries, but we certainly would expect some variability in associations based on levels of exposure. But I don't think we have the data yet to really say what levels of exposure are particularly important for preterm birth or if there's any sort of threshold.
And I think on the air pollution side, there has been a considerable amount of air pollution and preterm work in China. And they have shown also very similar results, and in many cases, or at least in some cases, have showed stronger results, and they do have higher levels of air pollution for the most part. And so I think the air pollution work is certainly applicable to other populations.
Another question, which forgive me if I don't phrase it correctly because I lost it getting disconnected again, is what would you say to women who, in terms of their ability to moderate the effects of oxidative stress, either through diet or exercise, or something that they can do to address that?
That's something that we're interested in investigating. So the studies that have looked at antioxidant supplementation during pregnancy in clinical trials, so looking particularly at like vitamin C, have not shown supplementation with vitamins to be very helpful for the prevention of preterm birth. We're interested in seeing if there is the ability to decrease oxidative stress levels during pregnancy with these supplementations. There is some data on that, but not a lot during pregnancy itself. So that's something that we're looking into for sure.
And a follow-up question actually for you, Kelly, is why are phthalate exposures higher in the US than Scandinavia?
I'm not sure exactly why that is. Probably differences in the exposure sources. So, for example, the use of phthalates in vinyl flooring, I don't know if that differs across the two areas. Differences in diet and personal care product use, but I'm not sure exactly.
Any additional questions? Or, Maria, do you see any up there that I might be missing?
No, I don't.
A bit of a, sorry about my connectivity issues.
Oh, no, that's fine.
Okay, I guess I had one last question for both of you is, both of you are also trying to integrate exposures to stressors into your work, and in your thinking about the relevance of stress for stress pathways towards preterm birth, and what you think overlap might be for pathways for impacts on for chemicals. And yeah, what are your thoughts about how best to integrate stress exposures into these environmental, chemical, and environmental pollution studies?
I can take a stab first. So we're really interested in looking at how psychological stress during pregnancy could interact with chemical exposure, because we think there might be overlap in some of the biologic pathways. So the primary hypothesis for how stress affects preterm birth is through activation of the HPA axis, but we're hypothesizing that it's possible that psychological stress can increase oxidative stress as well, and that if you have increases from chemical sources as well as psychological stress sources, then you could have an exacerbated response and a preterm birth. So assessing psychological stress is a little bit more difficult. My expertise is in biomarkers, and biomarkers of psychological stress are poor. So we're examining different matrices for looking at psychological stress, so looking at perceived stress, stressful life events, neighborhood stressors, and trying to figure out which one of these might be the best, and developing some new collaborations in order to better identify what is the best in the literature.
Yeah, that's interesting. I think, I know as part of ECHO, Rachel's very familiar with this, we'll be asking many of those types of questions across pretty large populations. And it will be interesting to see how they compare. But I know less about kind of the biomarker world, but I think it's always, I guess it's kind of a balance, because we want to find these pathways, but we also care about how people actually feel about their stress. So there's the stress, and then there's how we react to it, both on a kind of visceral level and on a biological level. And so I think there's certainly a lot of work to be done to kind of sort those out and understand the relationships between them. But yes,
Okay, this is a tough question. This is a tough question, but you have a group of folks who are also practitioners. What would you say to women about how they should, based on what you know about the research, about how to reduce the risk of preterm birth? Or can we say anything at this point?
I mean, air pollution is a tough one. A lot of it is based on kind of on where you live, more so than, you know, which is not an easily changeable thing in many cases. I think for me, I personally focus more on the sort of policy side of how we can change, you know, air pollution for everyone, and less so for an individual. Although I have to say, when I was pregnant, I rode my bike a little bit out of the way to avoid more traffic, both for safety and for air pollution reasons. But I don't know how much of an impact that could have possibly made.
Yeah.
And I think it's similar for phthalate exposure. You know, there have been some studies that show that if you modify your diet, need a fresh diet, or if you change your personal care product use, then you might be able to reduce your exposure levels. But there's other studies showing that such changes don't really have an effect. So I would say in this area, we're also kind of leaning more toward policy changes as being more important.
All right. Thank you, guys. I think this is a good place to wrap up, and also I've lost the list of questions due to my connectivity. Before we end the call, I would just want to give people a heads up about upcoming CHE calls in this series of 20 Pioneers Under 40. The next one will be on April 24th at 2 p.m. Eastern Time with Vanessa Galavis, who's a scientific advisor and toxicologist and environmental justice liaison with Cal EPA, and Ana Mascareñas, who's Assistant Director of Environmental Justice at the California Department of Toxic Substances Control. Again, this call is on April 24th at 2018. And I just wanted to thank everybody for attending this call and our presenters for outstanding presentations. And you can access the materials from this call and other calls on the CHE website that's advertising this series. I'm going to turn it back to our host.
Okay, thank you so much, Rachel. We are approaching the end of today's webinar. A video recording will be available on the CHE website soon, and tomorrow you will receive an email containing a link to the video. CHE's next webinar from the CHE Boston University Superfund Research Program Partnership will take place Tuesday, March 13th, and is titled Superstorms and Superfund Sites, Preventing Toxic Exposures from Climate Change Disasters. To learn more and to RSVP, please visit our website at healthandenvironment.org. If you are new to CHE and would like to stay updated about upcoming events and more, please sign up to receive our newsletter by selecting the Join Us tab at the top of any page on our website. Additionally, if you appreciate these CHE partnership webinars, bringing you the latest environmental health research for free, we encourage you to support CHE's ongoing work by making a tax-deductible donation via our secure website. Again, our website is healthandenvironment.org. With that, I would like to thank our speakers once more for taking the time to present today, and Rachel for her excellent moderation. Thank you so much for joining us, and have a great day.